talk about closed flap crown lengthening procedures using the erbium chromium YSGG 2780 nanometer laser. There's quite a few lasers on the market today. On the top left side, you get the Nd:YAG laser, soft tissue laser. Laser also used for periodontics, better known as the Lanner procedure. We get also a few diode lasers, serialized blue, the Epic 10, all diode lasers. It can use this for soft tissue, some deep soft tissue, home bleaching, or bleaching, in-office bleaching, depigmentation, also disinfection and root canal systems. CO2 laser, a laser not yet available in South Africa, Solaya. Also a good laser, all-round tissue laser, can be used on soft tissue as well as hard tissue. For example, very good for superficial intraoral lesions, for example, lichen planus. Then we get our two erbium lasers here, erbium YAG, photonal laser, and also we get our erbium chromium YSGG laser, the water laser. Okay, the degree of absorption and also the depth of penetration of lasers is mainly due to the absorption of their chromophores. If you look at the near-infrared spectrum, we've got your 532 KTP laser up to 1064. These lasers got a low absorption coefficient in water, therefore they've got a deeper penetration. If you go to the mid-infrared spectrum, erbium lasers, also the CO2 laser systems, the erbium lasers got a high affinity for water, also hydroxyapoptite, can therefore be used for hard as well as soft tissues. But their penetration is limited. For example, the erbium YAG laser has got a penetration about 15 microns into enamel. So these are the two lasers that I use in my practice, 2780 nanometers erbium chromium YSGG, also the diode laser, 940 nanometers. What I use it for in aesthetic procedures, closed flap crown lengthening procedures, gingivectomies, depigmentation, and also in-office bleaching. In the literature, there has been some studies in regards to the benefits of lasers in soft tissue. Most lasers can be used in soft tissue surgery, where they apply a photothermal effect. They achieve excellent hemostasis, especially the diode lasers, and also the erbium chromium YSGG has got a limited effect due to limited penetration. These lasers also cause less scarring. Healing is by secondary intention, and we also need less sutures. There's also some limited thermal damage and also better patient comfort due to the photobiomodulation effects of these laser systems. If you can just look at those two pictures there, this is a pre-op or post-op slide of a patient that received a marginal gingivectomy, and this picture was taken 3 weeks ago when the final restorations were placed. As you can see, no biological width problems, also some good healing in those cases. In the past, there was some concerns on the CO2 laser in regards to photothermal damage. You can see the CO2 laser, a lot of collateral damage, a lot of carbonization. If we compare that to the erbium group of lasers, they can effectively ablate bone with minimal thermal damage. Also, there is some studies advocating increased cell proliferation due to the regulation of protein expression, lack of vibration if you compare that to mechanical cutting or a drill, and also because of the ablation of the laser, it can be seen as also beneficial for the components of blood and vibrin, early healing. So instruments that we can use for crown lengthening procedures, the mechanical rotary instruments with open flap, that is still considered as the golden standard, but there's also some chances of some thermal damage to the surrounding tissue. Other instruments that we can use is hand instruments. They minimize the tissue damage, but there's limited access and also the efficiency is quite low. And the third technique that we can also use is for osteotomies is ultrasonic instruments. They're also effective using for incisions and also resection of osseous tissues. So this is a study by Silva in 2015. He evaluated a traditional, I can say, crown lengthening procedure. It was done by mechanical instrumentation, also open flap. And as you can see the results, out of 22 patients, the baseline crown length were 8.5 millimeters, after sutures 10.3, and also 6 months post-op 9.9 millimeters. So still a very good result and a good technique to use. Another interesting study, this was the first split mouth study that was done comparing flap and flapless crown lengthening procedures. On the right-hand side, they performed a flap, on the left-hand side without. And as you can see, the author had no significant difference in the difference between flap and flapless surgery. There was also some evidence of less inflammation, also faster healing in the flap-free group. But again, if you've got a thick bite type or a thick osseous ridge, it would be better to raise a flap. So what is the indications for laser-assisted crown lengthening procedures? Firstly, reduced clinical crown height and also excessive wear, gummy smile, uneven gingival contouring, relocation of the gingival margins, correction of the biological width. If we want to also reset the incisal plane and also want to avoid excessive long clinical crowns, and also access to subgingival caries and also tooth fractures. What's the considerations? Firstly, is there enough attached gingiva? The position of the frenulum, the bone crestal height, and also soft tissue bite type must be evaluated. Very important, periodontal status of the patient. Shall we use an open or closed flap approach? Also the lip mobility and the position of the lip must be evaluated. And treatment options. Can we maybe treat this patient orthodontically via extrusion or intrusion? Before we start these treatments, this is a very important concept. We must always do a proper examination and also always take in consideration the biological width. And the idea is also to maintain the biological width to prevent any post-op complications, which can include inflammation, loss of attachment, and also chronic pain. There's also, in patients, there's also the relationship between the osseous crest and also the gingival margin or the cement-to-enamel junction. There can be some variations. For example, a high crest can cause some risk of biological width violation, and as in a low crest can also cause some gingival recession or some black triangles. How do you plan these cases? Complete radiographical examination and also periodontal treatment. Firstly, diagnostic models, wax up of the ideal incisor and canine morphology, and then documentation of the current incisal edge and also the cement-enamel junction as well as the proposed edges. Sorry, guys. Here we go. Okay, so what's the protocol? Verification of the biological width and also the bone position with the periodontal probe. Then we mark the soft tissue with a laser or maybe a marker with the surgical guide. We do external bevel gingivectomy with a laser. After that procedure, we do bone sounding. Then we reevaluate the position of the osseous crest to the new gingival margin. And also osseous reduction with the laser, 3 millimeters subgingivally. And this is just to keep in consideration the biological width. Probing and evaluation, and with a diode laser, some photobiomodulation. The photobiomodulation will have an analgesic effect, will have some anti-inflammatory properties, and also will increase the healing. This is just an example of the surgical guide that the laboratory made, and we're just using the erbium laser on low power settings without water and little air, just to run around the ridges that the lab provided, so we can have an idea where the surgical site must be. This is an idea of the surgical outline, and after this we can proceed with gingivectomy. This is the photobiomodulation. We're using the bleaching handpiece from the Epic, and this is after every surgical procedure or a soft tissue procedure to improve the healing and also to minimize post-op discomfort. This is just a small video courtesy of Dr. Mark Cronshaw from the UK, just showcasing this procedure. Sorry if some of these slides is a bit out of focus. Here we go. Veneer was placed on the 1-1, infringement of the biological width. Again, he's using the water lathe to remove the soft tissue, gingivoplasty or gingivectomy. Also lower power settings than for bone surgery. Removal of the granulation tissue inside the pocket. As you see there, he marked the tip of the laser to 3 millimeters. This just gives you a good visual guide of how much reduction you should do. Also a bit more power settings, higher power settings, more water, more air, and also osseous reduction into the pocket. Very important to stay parallel to the long axis of the tooth. We sometimes also use bone chisels just to prevent gutturing. Gutturing is where not all the bone has been removed. Periodontal probe used for the verification of the biological width and also photobiomodulation with the tip removed. And you can see nice result after, it was 3 weeks after the surgical procedure. Okay, how long do you wait after surgery? In the literature, there's at this moment, not really consensus. Generally, after we've done the crown lengthening procedure with the laser, we wait a minimum of 6 months. In this period, we supply the patients with some laboratory-made provisional crowns, and after a 6 months period, re-evaluate, and then we can go further to make your final crown and bridge work. Some complications that can occur when we use a laser: damage to the root surface due to incorrect positioning of the tip, too high power settings, not enough irrigation, too little water, and it's also technique sensitive. Again, violation of the biological width, we can have some chronic inflammation, attachment loss, also recession. What should we do to avoid complications? Definitely proper diagnosis and treatment planning is essential. If there's thick tissues or osseous bone, rather think about the open flap approach. Thin tissues, they may be fragile, may cause recession. Beware of the perio patient. Do not use high power, high energy settings for a long period of time. Use the correct settings. And also consider lab-made provisionals for the next 6 months. All the laser manufacturers is expanding their product range. This is a new handpiece from Waterlays. It's called the Fractional Handpiece. This would be used in dermatology and also aesthetics. It's not on the market yet, but this is quite an interesting development that we can use also on the erbium chromium YHG laser. So the conclusion, dental lasers may provide dentists with a minimal invasive approach for hard as well as soft tissues. There is still some evidence lacking. Some split mouth studies is not yet available comparing laser crown lengthening procedures with open flap conventional techniques. And also the laser is not a magic wand. When you're in doubt, refer to a specialist. And thank you very much.